Welcome back to the deep dive. We spend a lot of time on this show talking about the what and the why of the world.
Yeah, we definitely do.
But today, I actually want to talk about the how. Specifically, how we measure something that feels, fundamentally unmeasurable.
Right, because if you ask just a regular person on the street, hey, how do you measure health? They're going to look at you like you're crazy.
Like by feeling good.
Yeah,
Or by not being in a hospital bed.
exactly. It feels entirely subjective. It's personal.
It is personal. But if you zoom out,
Yeah.
like imagine you are a government minister in Rwanda or, say, a grant director at the Gates Foundation.
Yeah.
You can't operate on vibes.
No, you absolutely cannot.
You have a limited pot of money. I mean, maybe it's billions of dollars, but it's still limited. And you have to sit down and decide, do I spend this on malaria nets or do I spend it on diabetes medication?
And you can't make that call unless you have a standardized unit of measurement. You essentially need a currency of health.
A currency of health. I love that. And that is exactly our mission today. We are doing a deep dive into the literal operating system of global health.
Yeah.
We're looking at Chapter 3 of Health Metrics and the Spread of Infectious Diseases.
Which, I should warn you, on the surface looks incredibly dry.
Oh, it is just a wall of acronyms.
It really is. It looks like an advanced algebra textbook.
Mm.
YLL, YLD, DALY, HALE.
Alphabet soup. But, and this is the core of our mission today, we're going to decode that soup. Because I would argue, and I know you agree, this is one of the most consequential chapters of text we've ever covered.
Oh, without a doubt. These aren't just obscure academic acronyms. These are the actual mathematical formulas that decide who gets saved and who gets left behind.
Right, so we're going to look at the literal equations used to calculate the global burden of disease. We want you to see how shifting a decimal point in a spreadsheet can literally change the lives of millions of people.
It's basically the accounting of human suffering, which I know sounds incredibly dark.
It does sound a little bleak.
But it's actually really hopeful, because once you can measure suffering, you can manage it. You can direct resources to fix it.
So let's crack this open. The source material starts with a concept that I think trips a lot of people up right out of the gate. And that's the idea that death isn't just a binary event.
Right. In the data world, not all deaths are created equal.
Which sounds controversial.
It does, but think about it. If we just counted bodies, just raw mortality rates, we would be missing a massive part of the picture.
Right, like if an 85-year-old dies of natural causes.
Exactly. Versus a 5-year-old who dies of malaria. Counting those simply as 2 deaths in a spreadsheet might be statistically accurate, but it feels morally incomplete.
Because the 5-year-old lost an entire future.
Precisely. And that brings us to the very first major metric we need to unpack, the YLL.
The years of life lost.
Yes. This metric specifically measures premature mortality.
Okay, so let's get into the math here. The source material gives us a clear formula. It's YLL equals N times LE.
Right. And the N is the easy part. That's just the raw number of premature deaths. You just count the death certificates. But the variable that causes all the debate, the one that really drives the global numbers, is that LE, life expectancy.
Yeah, and this is exactly where I got stuck reading the chapter. Because which life expectancy are we using? Like if I die in a country where the average lifespan is only 50, do you calculate my lost years based on that 50?
That is the crucial ethical question. And for a long time, there was genuine debate about this in the field. Because if you use the local life expectancy...
You're running into a trap.
A terrible ethical trap. You are essentially baking inequality right into the math. You'd be saying that a life in a low-income country is, quote-unquote, worth less in potential years than a life in a high-income country.
Wow. So if I died at 30, in a place where the average lifespan is 50, I've technically only lost 20 years. But if I die at 30 in Sweden, I've lost 50 years.
Exactly.
Yeah.
Just because the environment around you is harsher. And the global burden of disease studies, which is the framework this chapter really focuses on, they refuse to do that.
Thank goodness.
Yeah. Instead, they use what's called a standardized life table. They basically look at the longest lived population on Earth.
Which is usually the Japanese, right?
It is. In the current tables used, the standard life expectancy at birth is roughly 84.6 years.
84.6.
Right. So it completely levels the playing field. It doesn't matter if you are in New York, Nairobi, or New Delhi. If you die, we calculate what you could have lived if you had been in the ideal environment.
It treats the gap between the reality of your death and that 84-year benchmark as the actual loss.
Yeah.
Everyone gets the same potential.
Exactly.
Let's apply this to a real example. The source uses stroke as a primary example throughout the chapter, which I found incredibly helpful to visualize all this. Let's look at the YLL for stroke.
Stroke is the perfect example because it kills people across very different age brackets.
Right.
So let's run the exact numbers. Imagine you have an 80-year-old who dies of a stroke.
Okay.
We look at the standardized life table. At age 80, even in the absolute best case scenario, your remaining life expectancy is relatively short, maybe around 5 or 6 years.
So our formula, N, is 1 because it's one death, and LE is 6, so the YLL is just 6.
Correct. Now, contrast that. Take a 40-year-old who dies of a hemorrhagic stroke and is still 1. But at age 40, according to that Japanese standard table, they should have had about 45 more years to live.
So their YLL is 45.
Right. One death equals 6 years lost. The other death equals 45 years lost.
That's a huge difference in the spreadsheet.
It is. And when you sum that up across an entire global population, diseases that tend to kill young people, like road accidents, malaria, neonatal disorders, they produce massive YLL numbers, even if the total raw death count isn't the highest.
It effectively weights the entire health statistic toward youth. It heavily prioritizes saving the years that haven't been lived yet.
Which makes total sense if you're trying to keep a society functioning and growing.
Right.
And this is a massive, but focusing only on death misses half the story.
Because you can survive a stroke.
You can absolutely survive. And this is where we have to move from the equation of death to what we might call the equation of suffering. The YLD.
Years lived with disability.
This was a revolutionary shift in public health. For centuries, medicine was basically binary. You were either dead or you were alive.
Right. If you survived the surgery, you were a success.
Exactly. But YLLD says, wait a minute. If I survive a massive stroke, but I can't walk, I can't speak, and I'm in chronic pain for 20 years, is that a success in the exact same way as someone who makes a full 100% recovery?
It's capturing the quality of life. But I have to say, this seems way harder to calculate than YLL. I mean, death is a certificate. It's an objective fact. Disability is subjective. Like, if my back hurts today, does that count?
It does count, but it has to be weighted. And the formula for this is YLD equals P times DW, prevalence times disability weight.
Okay, let's talk about these weights. The DW, the chapter describes the scale from 0 to 1.
Yes. In this somewhat grim calculus, 0 represents perfect, pristine health. No issues at all. 1 represents death. Every single condition known to modern medicine has to be assigned a number somewhere between 0 and 1.
But who decides that number? That seems incredibly fraught. Who gets to say how bad a disease is?
It's highly debated. They use massive global surveys, trade-off scenarios. They essentially ask thousands of people, would you rather live 10 years in this health state or 5 years in perfectly good health, to mathematically derive these values.
Wow.
And for stroke, the source material gets very specific. They don't just have one generic stroke weight. They break it down heavily by severity.
Which makes sense. A mild transient stroke is very different from a massive brain bleed.
Drastically different. So let's look at the actual source numbers. A mild stroke has a disability weight of approximately 0.019.
0.019. That's tiny.
It's very small. It acknowledges that there is some minor impairment, but you're mostly functioning normally. Now, look at a moderate stroke. The weight jumps to around 0.193.
So it's roughly 10 times worse, mathematically speaking.
Right. But then look at a severe stroke. The disability weight jumps to approximately 0.57.
0.57. Just pause on that number for a second. That means the algorithm literally considers living 1 year with a severe stroke to be equivalent to losing over half a year of actual life.
Exactly. It's saying that being in that state is mathematically more than halfway to being dead.
That is shocking when you actually say it out loud.
It is shocking. But think about the aha moment this creates for a policymaker reading the data. If you have someone living with a severe stroke weight, 0.57, and they live like that for 10 years.
You just multiply it.
Right. That's 5.7 years lived with disability. That is a massive mathematical burden on the system and obviously on the individual.
And compared to the mild stroke,
a mild stroke is 0.019. You could theoretically live with that for 50 years. And your total YLD would still be less than 1. So the math is screaming at us. Preventing the severity of the stroke is almost as important as preventing the stroke itself.
it gives governments a tangible way to value rehabilitation. It gives you a way to value early interventions that turn what would be a severe stroke into a mild one.
Precisely. Now, there is another key variable in that formula, the P prevalence. And the text mentions something really interesting here, a massive shift in methodology that happened globally around 2010.
The shift from incidence to prevalence, yes. I feel like we really need to clarify these terms because I see them used interchangeably in the news all the time, but in epidemiology, they are totally different things.
Totally different. Think of a bathtub. Incidence is the flow of the water coming out of the faucet into the tub. It's the number of strictly new cases in a given year, like 500 new people got sick today. That's incidence.
Okay, and prevalence.
Prevalence is the total amount of water currently sitting in the tub. It's everyone who is actively sick right now, regardless of whether they were diagnosed yesterday or 10 years ago.
So why the big shift? Why did the Global Burden of Disease study stop using incidence and start using prevalence for these YLD calculations?
It was all about visibility. Think about a disease like diabetes or clinical depression or severe back pain. These conditions aren't usually fatal, and you don't get them new every single year. You get them once and you keep them.
Right. So if you only count new cases incidence, you might look at the data and see a really low number. You'd think, oh, this isn't a problem. But if you walk into an actual community clinic, the waiting room is packed.
Exactly. Incidence-based math was basically hiding the chronic disease burden. By switching to prevalence, suddenly the data actually reflected the reality of the clinic waiting room. It showed that while infectious diseases were killing people, driving up YLS, chronic diseases were crushing people over decades, driving up YLDs.
Sounds like it just made the data much more honest.
It did. And, crucially, it allowed us to finally combine these two worlds, the dead and the disabled.
Which brings us to the boss level metric, the one that basically runs the world of global health funding right now, the DALY.
The disability-adjusted life year.
And the formula here is just simple addition, right? DALY equals YLL plus YLD.
Simple addition, but with a profound implication. One DALY, one DALY, represents the literal loss of one full year of healthy life.
So if a country's data shows they have 1 million DALYs in stroke, that means 1 million years of perfectly healthy life have essentially evaporated from that population.
Correct. And the true beauty of the DALY is that it finally lets you compare apples and oranges. Or, in public health terms, heart attacks and depression.
Break that down for us.
Well, a massive heart attack has a huge YLL. It kills you instantly. Premature death. Depression, on the other hand, has a very low YLL. It rarely kills directly, though obviously suicide is a tragic factor. But depression has a massive YLD. It disables you, sometimes for decades.
So before DALYs, these two diseases were just in totally different buckets. You couldn't compare them. One was seen as a serious medical issue. The other was maybe dismissed as a lifestyle issue.
Exactly. But with DALYs, you can stack them right up against each other on the same spreadsheet.
And you might actually find that the total daily burden of mental health is higher than the burden of some fatal infectious diseases. It forces the funding to follow the actual human suffering, not just the coffins.
That's exactly what it does.
Okay, I want to challenge this a bit because
Okay.
we're sitting here in a studio praising the elegance of this math. But does this actually work? Do real governments actually look at these DALY spreadsheets and say, oh, wow, look at the numbers, let's completely change our national budget? Or is this just an academic exercise for epidemiologists?
Oh, it is absolutely happening in the real world. The chapter actually details a fantastic case study from Rwanda that proves this isn't just theory.
Walk us through that Rwanda case.
So, Rwanda has been incredibly proactive in rebuilding its entire health system over the last few decades. And for a long time, naturally, their primary focus was on infectious killers. HIV, tuberculosis, malaria. These were the obvious visible threats.
The ones producing those massive YLLs we talked about.
Right. But Rwanda's health ministry started looking really closely at the global burden of disease data, specifically the GBD 2021 results that are mentioned in the text. And they saw something in the DALYs that the naked eye might totally miss.
What did the data actually show them?
It showed a crossover, a really dangerous crossover. The DALYs from non-communicable diseases, or NCDs, we're talking about cardiovascular disease, diabetes, cancer, they were rising incredibly fast. In fact, in certain demographics, those chronic diseases were actually overtaking infectious diseases as the primary burden on the population.
Wow. That puts the government in a really tough spot, doesn't it? You have all your momentum, all your international donors, all your rural infrastructure perfectly set up to fight malaria. And the math steps in and says, hey, the enemy is completely changing.
It's a massive pivot. It's politically difficult to tell donors you need to shift focus. But because the dailies provided hard, undeniable mathematical evidence, the Rwandan health leadership acted on it. They didn't just file the report away in a cabinet. They shifted actual policy.
What did that actually look like on the ground for a citizen there?
It meant taking nurses and doctors who were lifelong experts in treating acute infections and suddenly training them to manage long-term chronic conditions. That is a totally different medical skill set.
Totally different.
It meant prioritizing actual funding for NCD prevention. Things like diet education, smoking cessation programs, rolling out widespread blood pressure control.
So these abstract acronyms, the YLLs and YLDs, they actually translated into a nurse in a rural clinic checking a patient's blood pressure instead of just handing out malaria pills.
Exactly. The math made the invisible chronic burden completely visible. Without dailies, without that specific calculation, that entire health system shift might have happened 10 years too late.
That really drives home why this chapter matters. It's not just bookkeeping, it's life-saving strategy.
It really is.
Now, we've spent almost this entire deep dive talking about loss, years lost, disability weights, disease burden. It's a little heavy. But the chapter does offer a counter perspective toward the end, doesn't it? It's a sort of glass half full metric.
It does, and I'm really glad the authors included it because public health data can get very depressing if you only ever measure what goes wrong. The metric they introduce is called HALE, HALE.
Healthy life expectancy.
Right. Think of this as the exact flip side of the daily coin. Regular life expectancy just asks, how long until you die? HALE asks, how long until you stop being healthy?
So it's calculating your health span, not just your lifespan.
Precisely. The basic calculation is roughly your total life expectancy minus the years lived with disability. It adjusts your total living years based on the actual quality of those years.
The text mentions something called the Sullivan method for running this simulation.
Yes. Without getting too deep into the advanced calculus of it, the Sullivan method basically takes those standard life tables and applies those exact same 0 to 1 disability weights we talked about earlier.
Okay, so how does that work in practice?
Well, if you live a full year with that severe stroke we discussed, the one with the 0.57 weight PEPIT, the HALE calculation subtracts the burden and only counts that as 0.43 of a quote-unquote healthy year.
Oh, wow. This highlights a really interesting modern problem, doesn't it?
Yeah.
Because we are getting very, very good at extending raw life expectancy. Modern medicine can easily keep you alive until you're 90, but are we actually extending healthy life expectancy at the exact same rate?
That is the defining question of 21st century medicine. If we use technology to extend your life by 10 years, but those 10 years are spent in severe cognitive decline or chronic pain, have we actually improved your HALE? Or did we just massively increase the daily burden on the health system?
HALE keeps us honest about the actual goal of medicine. The goal isn't just to maintain a pulse. The goal is a life.
Exactly. Quality over mere quantity.
Well, before we wrap up today, there was one tiny breadcrumb at the very end of the chapter that I found completely fascinating. We've moved from counting deaths to counting disability with dailies to measuring health span with HALE. But the authors mentioned an emerging concept for the future. WAHE.
Ah, yes. WAHE, well-being adjusted health expectancy.
Well-being. Now we are stepping out of biology and getting straight into philosophy.
We really are. The core idea is this. Public health has largely mastered measuring broken legs, blocked arteries, and viral loads. But what about happiness? What about social connection? What about a sense of fulfillment?
Can you imagine a global health metric that literally penalizes a country's score? Not because its people have heart disease, but because they are systematically lonely.
It sounds a bit like science fiction or maybe a Black Mirror episode. But if you look at the entire historical trajectory we just covered, from incidence to prevalence, from mere death to daily disability, we are constantly, relentlessly trying to capture a more holistic view of the human experience in our numbers. WAHE suggests that the next grand frontier in health metrics isn't biological at all, it's entirely social.
The literal math of happiness. That is going to be one incredibly complicated spreadsheet.
Extremely complicated. But if the history of global health shows us anything, some statistician out there is already working on the formula.
Well, let's leave it right there for you to ponder. From N times LE to the mathematical pursuit of happiness. Hopefully, the next time you see a news headline talking about global health burdens or a drop in life expectancy, you won't just see a flat number. You'll see the lost years, the disability weights, and the very real human decisions behind it.
Stay curious, everyone.
Thanks for diving in with us. We'll see you on the next one.